No, it should be slow. First of all, immunomodulation is such a difficult topic. Okay, yeah, I think we are live.
Okay, we are live. Yeah.
Yeah, good evening, everyone. So this is our 95th masterclass. This topic is slightly on advanced fertility, like an advanced fertility class, where we are talking about immunomodulation and use of immunomodulators in FET. I will not waste much time. So let's just go to the topic right away. Yeah, you can take over, please.
Yeah. So I will also not waste any time, and we will straight actually go to immunomodulation only. Okay. Now, what we have to understand as far as immunomodulation is concerned, no, is this thing. See, let's assume I am drawing maternal side here. Okay. And I am drawing fetus here. Okay. So there is going to be fetal villi like this, no? Okay. And then there is going to be maternal side also. Both these people this is going to be the villus. So this is the maternal side and this is going to be villi. Now, before all this happens, what this villi is going to come from? It is basically going to come from a hatched blastocyst, correct? No? A blastocyst which has completely hatched out from the zona pellucida. Okay. And that will ignite all this reaction. So then there will be an inner cell mass here, and this inner cell mass from the blastocyst, basically the embryo, is going to ignite all this reaction. So two people are working simultaneously. Basically, this embryo which has come here, this embryo is a foreign body. Okay. So there is going to be two reactions. One is going to be a rejection reaction, and second is going to be an acceptance reaction. Okay. As a result of this, because this embryo is going to be formed from 50% male partner, as a result of this, it is called as something like a semi-allogenic. Why semi-allogenic? It is a semi-allogenic graft. Why? Because 50% contribution is coming from mother. Okay, 50% is coming from here. So it is only semi-allogenic. All right. So embryo itself is going to give rise to a lot of mechanisms wherein it is going to be accepted. Okay. But the most important thing is for embryo to be accepted, it has to be euploid embryo. Now, this is going to be your take-home point for this session. That whenever you are planning to use any form of immunomodulator in an FET cycle, the most important thing is it has to be a euploid embryo. All right. As a result of this, in order to get a euploid embryo, doing a PGTA or doing an NICS over this embryo is absolutely mandatory for you. And your immunomodulators should only be used when you are sure that you are putting in an euploid embryo. All right. Now, what typically happens is there is a lot of reaction which is going to happen from the maternal side in this situation. And here you are supposed to remember one important human being. Okay, so I'm drawing one person in brown color. This brown colored person is called as macrophages. Okay. I am also drawing another human being in a green color. Okay, and this green color human being is going to be many inside. Okay, now this many human beings are basically your T helper cells. Okay, I'm drawing many like this. So what type of T helper cells are present here? Okay, you have two types of T helper cells. So I'll draw both of them, one in green and one in blue. Okay, so you have green, which is helper cells number 1. Okay, and you have blue, which is helper cells number 2. Now remember, there is always a TH1 helper cell 1 by helper cell 2 ka ratio. And in pregnancy, always there is an increase in helper cell number 2 and reduction in helper cell number 1. Bas. Don't think of anything else. Just to tell you, both of these are going to be part of T lymphocytes. T lymphocytes are basically your CD4 cells. These guys help this guy. Okay, the role of both these cells is to go and help the macrophage in ensuring that there is a control in infection. Okay. As a result of this, whenever there is a loss of T lymphocytes, whenever there is a loss of CD4, that is something which happens as a result of human immunodeficiency virus, which cause reduction in CD4, and that is the reason why it is called as a immunocompromised state. Now, remember, this is a very important example. All right. So, in your pregnancy, there are some T cells which are going to be down regulated and some helper cells which are going to be upregulated. A ratio of T hyper cells 1 by T hyper cells 2 is usually going to be approximately less than 10. So that is going to be T hyper cells. Let's say if they are 100 in number, okay, this guy is going to be 12. Okay, so that ratio is less than 10. And this ratio is important to be maintained if a euploid embryo has to have a healthy pregnancy. Okay, just please remember this much. Now, due to whatever reason, there is an alteration in this. Due to whatever reason, the number of macrophages has gone up. Due to whatever reason, activity of something called as NK cells has gone up. Due to whatever reason, plasma cells concentration has gone down. All of this is going to affect the euploid embryo, and all of this is going to cause an unhealthy pregnancy. Okay. So, whenever you plan to use your immunomodulators, okay, as far as your practice is concerned, you are basically trying to use and ensure that this concentration is going to be maintained nicely inside the uterus so that the euploid embryo can give rise to a healthy pregnancy. Okay, with this much understanding, kindly understand now that whenever you are talking of immunomodulators, I will just very quickly draw all of them. So first I will just go on to the indications where some of you can try to use this. Okay. Basically, remember, they are not great solutions. Okay. Recurrent pregnancy loss, recurrent implantation failure. These two are your primary indications to use any form of immunotherapy, and immunomodulator is just one form of this therapy. All right. Along with that, as I have mentioned, it is absolutely mandatory for you to have a euploid embryo. You cannot do this in a euploid embryo or in an abnormal pelvis. Okay, that means the pelvis has to be free of fibroid, it has to be free of polyp, it has to be free of endometriosis, it has to be free of adenomyosis, it has to be free of PID, it has to be free of endometrial TB, it has to be free of an ovarian abscess. It has to be free of everything. It has to be a normal pelvis with recurrent pregnancy loss, recurrent implantation failure, or any other form of blood supports like ANA positive titers, SLE positive patient, psoriatic patient positive, ankylosing spondylosis positive, post-transplant patients positive. In any of this indication, you can try to use your immunomodulation. Okay. So immunomodulation, as a routine practitioner, you should remember 3 or 4 important drugs which you are going to use. Prednisolone, HCQS, tacrolimus. I'll put tacrolimus and cyclosporin both together because people will prefer obviously to use tacrolimus and not cyclosporin. IVIG and intralipids. These two I will put in the same category. Okay. Prednisolone is Vizolone, which we discussed yesterday. I already told you Vizolone is basically going to be an immunosuppressant. Whenever there is an immunosuppression, obviously, when the macrophage is presenting the antigen to the T helper cell, immunity of the T helper cell is suppressed, and that is how your prednisolone may help. HCQS basically is a wonderful drug. Your standard dosage is going to be 200 BD. It is to be given when you have a broad spectrum immunoreaction. That means anti-nuclear antibody. ANA stands for anti-nuclear antibody. That means it is going to affect against the nucleus of macrophages, nucleus of T cells, nucleus of beta lymphocytes. It will go and affect everything. As a result of which, HCQS 200 BD can be useful in all these situations. However, HCQS and anti-ANA positive, you should always rule out anti-TPO antibodies, which is way more common, okay, than any other form of antibodies which you can try to think of. Obviously, it has got a limited role in APLA antibodies, limited role in anti-cardiolipin antibodies. All right. Then we come to tacrolimus and cyclosporin. You have ANA positive or negative. You have tried prednisolone, not worked. That is the situation when you can use tacrolimus. The standard dosage is 2 to 3 milligrams to be taken once in a day. All these drugs are usually given to the patient approximately 5 days prior to embryo transfer. Tacrolimus definitely we will give around 4 to 5 days prior to the embryo transfer, 2 to 3 milligrams per day. Tacrolimus is somebody which is widely used in transplant medicine. And when they use it in transplant medicine, they will obviously look at the serum tacrolimus values in order to ensure suppression. But this is the standard dose which is given in a pregnancy and in embryo transfer, and this is a micro dose. Basically, this is done to maintain a TH1 to TH2 ratio of less than 10. This is a simple blood test, really not rocket science, commonly done by flow cytometry. If you go to any good place where flow cytometry is happening, you will understand that helper cell 1 is predominantly going to secrete interferon gamma, and TH2 is going to secrete IL-4. So you can't really measure ratio of 1 and 2. They measure a ratio of interferon gamma to interleukin 4, and they give you the outcomes. Okay. Also remember, guys, there can be lot of drugs which can cause a falsely elevated anti-nuclear antibody values. And in those situations, prednisolone no role, HCQS no role, tacrolimus has got no role. Understanding? IVIG and intralipids we have already discussed as immunomodulators. The role in whatever you do is going to be absolutely negligible, and they are to be done in cases where you are having something called as an idiopathic recurrent pregnancy loss or a recurrent implantation failure. After learning so much of information in the last 15 minutes about immunomodulation, the most important thing which people should remember as far as immunomodulation is concerned is that immunomodulation is something which you are supposed to use sparingly as far as FET protocols are concerned. The biggest cuteness which people think in using immunomodulator is like, oh, I also use antilipids in my practice, something like that. Remember one thing, before embarking on this stupidity, it is important that you establish euploid embryos. Okay. In order for you to establish euploid embryos, it is going to be very, very important that you follow an excellent ovarian stimulation regimen. Apart from this, you should have a very good laboratory optimized to carry out biopsies or NICS, because even NICS requires a good amount of plate preparation for you to do. And before you give anything like this in a country like India, do a hysteroscopy, rule out endometritis, because in India, endometritis and antibiotics will take care of 80% of the problems which are going to occur as far as implantation failures are going to occur. Okay. When you do a hysteroscopy, in majority of the times where there are previous 2 IVF cycle failed, when you do a hysteroscopy, you are going to find endometritis. When you take a DICE panel, you will find beautiful bacteria, and a course of approximately 25 days of antibiotics is going to solve the problem, because an altered T helper 1 to helper 2 ratio is the commonest in infections, guys. And what is the most commonest infection in India? Cervical ectropion causing HPV virus infestation. You meet a colposcopist, they will want to speak for 45 days about human papilloma virus, about something like that. That is also one of the cause of having implantation failures, which is why in your fertility practice, local examination of the cervix is given so much importance prior to starting fertility treatments. All right. So in my opinion, your take home point through immunomodulators is that it's got a beautiful show of value, no tension at all. Okay. But before you switch on to immunomodulators, it is very important to do hysteroscopy, rule out infection, very important to establish euploid embryos. See, I am somebody who is entertaining a patient who has had at least 2 IVF cycles failed. So basically, I have an opportunity to use tacrolimus. I have an opportunity to do LIT. I have an opportunity to do everything in every patient. Understanding? And 80% of these patients get cured
with hysteroscopy. Simply with hysteroscopy. Okay, that is the most important take-home point. The another important point which a level 2 clinic should remember in this is, don't call monkeys to do your hysteroscopic surgeries. Call qualified hysteroscopic surgeons to do your hysteroscopic surgeries. A qualified hysteroscopic surgeon is going to charge you approximately 2 or 3 times compared to a monkey. Understanding? He may be slightly expensive, but he will pick up chronic endometritis, he will pick up micropolyps, he will pick up abnormal vascularization inside the uterus, which will be a very much more important cause of recurrent implantation failure or a recurrent pregnancy loss as compared to giving, let's say, prednisolone or tacrolimus in your practice. So follow that protocol. Involve a good endoscopic surgeon. Let him do a good hysteroscopy for your patient. And once he do a good hysteroscopy for your patient, your outcomes will definitely improve. Obviously, conclusion line, after all this has failed, everything is normal. And if it is an idiopathic cause, you may consider to add a combination of prednisolone plus tacrolimus in your practice. It is a very effective protocol in idiopathic thing if you want to add. We have seen so many patients in whom LIT is done, and people who is doing LIT has such less confidence on LIT themselves, okay, that after LIT they are suggesting to give tacrolimus plus prednisolone plus intralipids. What nonsense! The mechanism is a completely different between LIT, intralipids, prednisolone and tacrolimus. You can't really experiment with all these things for all the patients and say, oh, I get so good pregnancy rates after LIT because after LIT, I give intralipid, tacrolimus and Vizolone to all my patients. So basically, the patient was going to become pregnant any which ways. Doing LIT was just commercialization. Keep this in your mind. If you keep this in your mind and think like this, probably it will benefit your patients and your practice. And with this much, I conclude. Thank you so much. And I can probably answer many questions on this because reproductive immunology is very close to my heart. And we have a reproductive immunology laboratory with almost all testing facilities in-house. So I can answer many questions, no problem.
There are a couple of questions here. Is there any test to check T helper cell ratio?
Yeah, flow cytometry will help you. TH1 by TH2, but they will check interferon gamma versus IL-4.
How many
It's
weeks
done on immunochemiluminescence. It's a commonly available kit.
How much does it cost?
I think 7,800 or 8,000 or something.
Up to how many weeks of pregnancy immunomodulators to be continued?
People will continue at till 34 weeks, stating that it will be very good in reducing preeclampsia, IUGR and all these things. But we normally stop at 8 weeks.
Okay, so you talked about the embryo, the euploid embryo being the most important thing when you're talking about the immune rejection from the mother. So in your practice, so if there is a patient with say like 2 or 3 IVF cycle failure where you're thinking that it could be implantation failure. So in like a flow chart, like what are the tests that you would advise? Say like they have not done anything, they have just done straight ICSI and no tests like to evaluate. So what are these tests that you would do?
No. See, honestly speaking, we will really want to do a 3D pelvis the first if it has not been done.
Okay.
If the 3D pelvis is done already, many people come with a 3D pelvis and hysteroscopy also, madam.
Yeah.
So if it is already been done, then we don't want to obviously repeat it. But we want to go ahead with NICS for these patients.
Yeah.
Okay, in their next cycle. Once it is a euploid embryo and even a euploid embryo has failed, that is when you are going to put your nose inside it and start evaluating for all these types of things.
So you are saying that you will establish an euploid embryo being failed in such couples and then you...
100%. It's not me telling. If you read even the most stupidest paper which is published as far as immunomodulation is concerned, the primary criteria to give immunomodulation is a euploid embryo. It is not anybody else.
Yeah, even for a 32-year-old who has had failed IVF cycles and still offer NICS or
absolutely
invasive testing to in preference to starting all this?
Yes, the same reason is the reason why people are doing karyotyping for recurrent pregnancy loss. If you have two failed abortions, why you should do karyotyping? You should do karyotyping, because karyotyping is somebody who is going to tell you is the status of that embryo euploid, right? If the couple is having a normal karyotype, you are assuming that, okay, most probably the embryo might have been a euploid embryo, and that is why I am evaluating. That is the reason after second abortion, people recommend POC karyotype.
Yeah.
Why recommend POC karyotype? Because if POC karyotype gives you abnormal embryo, you are a very happy person, no? Oh, great, it was an abnormal embryo, God has aborted, get lost. If it is a euploid embryo which is got aborted on a POC microarray, right, you are going to be worried. Why did a chromosomally normal embryo get aborted at 8 weeks? Correct? Which establishes even otherwise the importance of having euploid embryo in your practice.
Okay, so take the situation between like two IVF failures where it failed to implant and cases of two abortions. So in this situation, do you change anything? Like, of course, I mean, in both situations, I think NICS or invasive PGS may be required. But other than that, is there anything that you change in your approach?
No. See, if it is a couple who has done 2 abortions or 3 abortions, no, and they are wanting to try naturally. Now, when they are wanting to try naturally, I will do an ovulation induction cycle. I will not just allow them to try naturally. That is one important thing. In an IVF cycle question, that was the second part of the question which you asked me. In the IVF cycle, 100%, I will go ahead with my type of stimulation protocol, either a luteal phase stimulation or a random start stimulation, and I will definitely do an NICS.
So in your situation, see, majority of the patients that you treat will come just on any random day of their cycle, and you start the stimulation mostly as a random start protocol. Even your patients in Bangalore, I have done that as a stimulation protocol. But in this, like in the past 1 year, 1.5 years, I have seen that you're doing more and more of random start stimulation. So is the stimulation protocol in any way contributes to more euploid embryo, you think? I mean,
Definitely. Quality of drugs used, stimulation protocol given, monitoring of this thing, I mean, your monitoring and your finally embryo handling. Everything is going to ensure formation of a good euploid embryo, because in all these situations, you are going to try to get that best oocyte. One extra oocyte is going to give you a potential 1 extra euploid embryo, which is a very big thing for people.
So also in these situations, I mean, do you do anything additional in your embryology lab? Okay, I mean, we are talking about immunomodulators and all this stuff. Do you do
Actually, it is in my embryology lab, if you see, and if I think you have spoken to me so many times on it. My culture practices is a very good practice. My plate preparation is very, very excellent. So there is no hypoxia in my plates. If I cut it down to one sentence, the amount of hypoxia in my plates is going to be absolutely minimal. Okay, which does not cause that centrioles and that DNA inside to suffer from hypoxia at all. Okay, I will have a mandatory plate change at day 3. Mandatory. Even if I'm doing everything on day 5, my plate change is mandatory. Okay, on day 3. All these small points is going to then ultimately add up to a decent success rate to the patient.
Okay, yeah. I think we'll take the rest of the questions on WhatsApp, because this will be quite elaborate discussion. Yeah, but thank you so much. I think it was wonderful for you to like take a session on these drugs. And I mean, there were almost like close to 130 people who joined. And I think this is a very good class for fertility practitioners who want to really know as to where the situation is as of now when they are talking about immunomodulators, because we see more and more patients who have failed before being on these drugs, like say cyclosporin, tacrolimus, IVIG. Today, your patient told that she had used IVIG in her previous cycle, which ended up in a missed abortion at 7 weeks. So this was quite good. So thank you very much. So I thank everyone who joined for this class. Though it was quite advanced, I hope everybody understood what was supposed to be given as a take-home message. Thank you.
Thanks.